Welcome to the Hospital Medicine Unplugged podcast. Today we're doing a clinical deep dive into, well, one of the toughest and most prognostically serious complications we manage on the inpatient side, hepatic encephalopathy, or HE. We're going to focus on the evidence-based diagnosis and the systematic management.
Yeah, this is definitely an area where, being systematic and guideline-driven really truly makes a difference in survival. We're not just treating a symptom here. HE is a major clinical landmark.
Right.
When overt HE develops in someone with cirrhosis, it signals a really profound shift in their illness trajectory. I mean, the data is pretty sobering. We're talking about one-year mortality rates that can, unfortunately, top 50% for these folks.
Absolutely, and that stark reality really shapes our goal today. The morbidity is huge, the healthcare costs, the readmissions. It's an enormous burden for patients and the system.
Yeah.
HE recurrence is actually the single biggest reason cirrhotic patients get readmitted after decompensation.
Mm-hmm.
So our aim here is to really distill the core clinical must-dos and the latest guidance, pulling mainly from the SCCM and AASLD guidelines to make sure our inpatient approach is truly locked down, evidence-based, right from admission.
Precisely. We need to move beyond just reflexively ordering lactulose. It has to be a comprehensive, multi-pronged strategy, meticulous in diagnosis, really exhaustive in hunting down those precipitants, and, importantly, optimized for long-term therapy even before we start thinking discharge.
Okay, so let's start at the beginning. The clinical definition and really understanding the full spectrum of HE that we as hospitalists need to recognize.
So the formal definition is essentially brain dysfunction that's caused by liver insufficiency and more portosystemic shunting.
Sure.
And it shows up as this really wide range of neuropsychiatric issues. Critically, the spectrum goes from very, very subtle cognitive impairment, what we call covert HE, all the way to profound coma, which is overt HE.
And it's often that covert end of the spectrum, isn't it, that can kind of trip us up and lead to some dangerous situations. Minimal HE might only be picked up with specialized testing, like psychometric tests, outpatient.
Right.
But clinically, that same patient might present with these subtle things. Maybe a shortened attention span, trouble managing their meds, maybe their sleep-wake cycle is off. They might look okay at first glance, but functionally, they're impaired.
That's exactly it. And that's why having a rigorous classification system is so important. We basically classify HE along two lines. First, what's the underlying cause? And second, how severe is it? Which we standardize using the West Haven criteria.
Let's hit the underlying disease types first. I think it's safe to say type C is the vast majority of what we encounter in hospital medicine.
Oh, absolutely. Type C is the HE that we see with chronic cirrhosis and portal hypertension. That's really our bread and butter, the slower progressive decline we manage day in and day out. Type A, that's different. It happens in acute liver failure. Often comes on fast, very high risk of life-threatening cerebral edema, needs an immediate ICU consult, usually transfer. Yeah. And type B is pretty real. That's from portal systemic shunting, either spontaneous or surgical, but without intrinsic liver disease itself.
Okay, so moving to severity, the West Haven criteria, these are basically the universal language for greeting HE, right? We have to be really meticulous using them, not just at baseline, but for tracking progress too. Let's walk through the key grades.
Sure. So grade 0 is essentially clinical normality. Minimal HE might be detectable, but only with testing. Grade 1 is where we see the first overt clinical changes, maybe subtle personality shifts, a trivial lack of awareness, perhaps mild confusion or anxiety. And importantly, covert HE includes both that minimal HE and grade 1. This subtle end is definitely easy to miss in a quick assessment.
Then we get into the more clearly overt grades, starting with grade 2. This is often where the diagnosis becomes, pretty hard to ignore on the wards.
Yeah, grade 2 is characterized by definite lethargy, apathy, noticeable personality changes. The patient's usually disoriented to time, maybe not place or person yet. And crucially, this is usually the grade where we first reliably pick up asterisks, that flapping tremor, which is, a classic physical sign of metabolic encephalopathy.
And then the higher grades, grade 3 and 4, really demand immediate thought about airway management and potentially ICU transfer.
Definitely. Grade 3 signifies somnolence or semi-stupor. The patient's really only responsive to strong stimuli, painful or loud verbal cues. They're grossly confused, maybe agitated or combative. And grade 4 is frank coma, unresponsive even to painful stimuli. Recognizing that jump from grade 2 to grade 3, especially with a falling Glasgow Coma Scale score, should immediately trigger thoughts about securing the airway.
Okay. Now let's get into the why. We always talk about hyperammonemia, and it's central, sure, but the pathophysiology is actually a lot richer, more complex than just high ammonia levels. You mentioned a pathophysiologic triad.
Yes, exactly. Hyperammonemia is the cornerstone, no doubt. Ammonia comes mainly from nitrogen metabolism by bacteria in the gut, right? And the failing liver just can't clear it effectively through the urea cycle, so high levels cross the blood-brain barrier.
And once it's in the brain.
Inside the brain, astrocytes try to detoxify it rapidly using the glutamine synthetase pathway. This converts glutamate into glutamine.
Okay, but why does that detoxification process cause the symptoms we see?
Because glutamine acts as an osmol. So as glutamine concentration rises inside the astrocyte, it pulls water into the cell osmotically. This leads to astrocyte swelling. That swelling contributes to cerebral edema, especially dramatic in acute liver failure, and it messes up neuronal signaling networks, altering neurotransmission.
But if we only focus on ammonia, we miss the other two really critical parts of this triad, especially relevant for our hospitalized patients who might also be septic, right? That's inflammation and infection.
Absolutely critical. The synergy between inflammation and systemic infection is huge. Any systemic inflammatory response, whether it's a strep pneumonia or a staph cellulitis, releases pro-inflammatory cytokines like IL-6, TNF-alpha. These cytokines actually amplify ammonia's toxicity, partly by making the blood-brain barrier leakier. Plus, the inflammation itself fuels oxidative stress in the brain, speeding up neuronal dysfunction. It becomes this vicious cycle where the infection doesn't just trigger the HE episode, it makes the existing hyperammonemia way more damaging.
So systemic inflammation kind of prompts the door open for ammonia to cause more trouble.
Precisely. And the third piece of that triad is the altered gut microbiota itself. In cirrhosis, the gut bacteria aren't just passively churning out ammonia. This dysbiosis, this imbalance, also contributes to the buildup of other neurotoxins. And it happens alongside these profound electrolyte disturbances we often see. Hyponatremia low sodium is common in cirrhosis and directly worsens neuropsychiatric symptoms. Plus, it seriously bumps up the risk of cerebral edema, especially when astrocytes are already swollen. And we also have to be super vigilant about hypokalemia low potassium, because low potassium actually makes the kidneys produce more ammonia, increasing the total systemic load.
Okay, so we've got the clinical picture and the why. Now, let's talk diagnostics in the acute setting. The key principle, as you said, is that HE diagnosis is primarily clinical neuropsychiatric symptoms in someone with known or suspected liver disease.
That is probably the single most important sentence for any hospitalist managing these patients. HE is fundamentally a diagnosis of exclusion, which means we must have a meticulous, systematic screening process to rule out every potential alternative or concurrent cause of altered mental status before we land on HE.
And that differential is huge, right? Metabolic, structural, infectious, drug-related causes. What are some of the common diagnostic pitfalls, where we might stop the workup too soon?
I think the most dangerous one is attribution error, just assuming it's HE in a known cirrhotic without doing the full workup. We absolutely have to exclude sepsis-associated encephalopathy. It can look almost identical to HE grade 2 or 3, but obviously requires rapid source control, maybe pressors. We also need to look for uremic encephalopathy, profound hypoglycemia, and those acute electrolyte issues, especially severe hyponatremia, low sodium. So the basic labs are mandatory: a complete metabolic panel, LFTs, CBC, and definitely blood cultures if there's any hint of infection.
Let's focus for a second on the iatrogenic causes, the ones we might have caused ourselves.
Right.
This seems like the area where we can intervene fastest.
Oh, incredibly common precipitants. You have to scrutinize that medication list for any CNS active drug, especially benzodiazepines, sedatives, opioids, even sometimes high doses of certain antidepressants. Think about it. A patient with maybe underlying grade 1 HE gets even a single dose of a benzodiazepine for anxiety or sleep, and boom, they can easily tip right into grade 3 somnolence. We also have to actively rule out alcohol withdrawal delirium. It has unique features: hyperthermia, marked autonomic instability, and its treatment is completely different from HE.
Okay, so when do we pull the trigger on neuroimaging? Obviously, we can't CT scan every altered patient, but the risk calculus is different in cirrhosis.
Neuroimaging becomes mandatory if there's anything atypical about the presentation, particularly if it's not symmetrical. So you need a non-contrast head CT immediately for any new focal neurologic deficits, any new seizure activity, or if the encephalopathy just isn't clearing up after fixing simple precipitants and checking initial labs. Primarily, we're looking to rule out structural things like an intracerebral bleed, an acute stroke, or maybe a subdural hematoma, all things that patients with cirrhosis and coagulopathy are more prone to.
And what if the patient's getting worse quickly, or the CT is negative? Are we done imaging?
Not necessarily. In type A, the acute liver failure setting, we might use CT specifically to look for signs of cerebral edema. In type C, our usual cirrhosis patients, if the picture is still murky, an MRI might be needed down the line. It could show subacute strokes or sometimes specific signs you see in chronic HE, like T1 hyperintensities in the globus pallidus.
Okay, now let's tackle the elephant in the room, the thing that plagues every house staff team and nursing staff everywhere. Serum ammonia. Why does checking serum ammonia levels persist when guidelines pretty explicitly say not to use it for monitoring?
Ah, yes, this is such a critical teaching point. Look, a serum ammonia level is typically elevated in HE, and getting one initially can be useful maybe to help confirm hyperammonemia is present in an altered patient. But, and this is a big, but is neither specific for HE nor required for the diagnosis. Ammonia levels swing wildly based on how the blood was drawn, how quickly it got to the lab, recent bowel movements, protein intake, and most critically, routine measurement of serum ammonia is not recommended for monitoring the patient's clinical status or how they're responding to treatment. We see people chase this number because, well, it's a number, it feels objective. But chasing it distracts from the real gold standard, the clinical assessment, the West Haven grade.
So the labs we should be tracking are the ones related to the differential diagnosis and identifying those potential precipitants we talked about.
Exactly. We need that full screen. Electrolytes and renal function to look for low sodium or uremia, coags to assess GI bleeding risk, CBC, blood cultures if infection's on the table. We should only really move to CSF analysis, like a lumbar puncture, if there's a really strong clinical suspicion for a CNS infection, fever, neck stiffness, or maybe a lack of any systemic findings that would explain the altered mental status.
And lastly, on diagnostics, when does the electroencephalogram, the EEG, come into play?
EEG is recommended mainly when the altered mental status remains unexplained, especially if we're worried about non-convulsive status epilepticus or other subclinical seizure activity, which can sometimes just look like persistent stupor. The classic EEG finding in advanced HE is generalized slowing, particularly these high-amplitude, slowed triphasic waves. It helps confirm a metabolic process is likely, but again, it doesn't replace the need for that thorough clinical exclusion of mimics.
Okay, so once we've clinically landed on the HE diagnosis, management needs to be immediate. But even before we jump to meds, we have to talk about what you stressed earlier, the single most critical first step: finding and aggressively treating any precipitating factors.
This right here is often the difference between turning the ship around quickly versus a really long, complicated hospital stay. If you don't find and fix what tipped them over, even maximal ammonia-lowering therapy is probably going to struggle, maybe even fail. We need a systematic checklist approach every single time.
So what are the absolute must-check boxes on that list for us hospitalists?
I think of it in 4 main buckets: infection, GI bleeding, acute kidney injury, AKI, and constipation dehydration. Infection, especially spontaneous bacterial peritonitis, SBP, is probably the most common trigger we see. If a patient with known ascites comes in with HE, you need a very low threshold for a diagnostic paracentesis. Even if they don't have classic belly pain or fever, altered mental status alone could be the only sign of an occult SBP.
That's such a critical point. Don't wait for fever or abdominal pain to tap that ascites in an altered cirrhotic.
Couldn't agree more. For GI bleeding, obviously, rapid endoscopy, fixing any coagulopathy is key blood. Setting the gut is just a massive protein load waiting to become ammonia. AKI, whether it's pre-renal from dehydration or something intrinsic, messes things up by reducing ammonia clearance and complicating our treatments.
And we have to be super careful about electrolytes beyond just volume status, right?
Absolutely. Low sodium and low potassium are non-negotiable targets. We talked about hypokalemia, low potassium directly boosting renal ammonia production. You have to replete potassium aggressively. And always, always double check for those iatrogenic precipitants because they're often the easiest to fix. Did they stop taking their home lactulose or rifaximin? Did someone just start them on an opioid for pain or a benzodiazepine?
It's quite sobering when you look at the data showing that having multiple concurrent precipitants isn't unusual, and it clearly correlates with a much worse prognosis, higher mortality, greater chance of needing an urgent liver transplant, EVAL.
Yeah, that finding really underscores why we need admission protocols that force us to look for all the potential factors, not just stopping after we find the first one.
Okay, moving to the cornerstone pharmacologic treatment. Nonabsorbable disaccharides, NADs, which for us usually means lactulose. This is first line, unequivocally recommended by both SCCM and AASLD.
Lactulose is absolutely the cornerstone. Its mechanism is kind of twofold. It's an osmotic laxative So it physically clears out ammonia-producing stuff from the gut, but maybe more importantly, it acidifies the colon's pH.
Right.
That lower pH favors the conversion of the easily diffusible ammonia gas, NH3, into the non-diffusible ammonium ion, NH4+, effectively trapping that nitrogen in the colon so it gets excreted. And the evidence, meta-analyses, even acknowledging some risks of bias in the studies, they do confirm that NADs reduce HE incidence, serious liver-related complications, and even mortality in overt HE.
Now, the key with lactulose, which often gets messed up on the wards, is the titration strategy. It's not just a fixed dose, right?
No, definitely not.
Yeah.
It's all about titration, playing the game to hit a specific clinical endpoint. 2 to 3 soft, ideally mushy bowel movements per day. For that initial aggressive therapy in someone with overt HE, the usual approach is something like 25 milliliters of lactulose given orally or down an NG tube maybe every 1 to 2 hours until you achieve catharsis, basically, until they have a large bowel movement. You're flushing the system.
Good.
Once that happens, then you back off to a maintenance dose, maybe 15 to 30 milliliters every 8 to 12 hours, but you must adjust it daily based on hitting that 2-3 BM target.
And for the really sick patient, the grade 3 or grade 4 who can't take anything by mouth, the retention enema becomes critical for rapid clearance.
Correct. A lactulose retention enema, typically like 300 milliliters of lactulose mixed in 700 milliliters of water or saline, held for 30 to 60 minutes if possible. That's necessary for quick catharsis if they can't take oral. But we shouldn't just rely on enemas alone. You want to start oral or NG therapy as soon as they can tolerate it.
Okay, finally, on this cornerstone section, let's just take a moment to really emphatically debunk the persistent myth of protein restriction. This idea just won't die, despite strong evidence against it.
Oh, it absolutely needs to stop. Protein restriction is not recommended in managing HE, period. Patients with cirrhosis need adequate protein, usually around 1.2 to 1.5 grams per kilogram per day to prevent muscle wasting, sarcopenia, which itself is a huge driver of mortality and poor quality of life.
Right.
Studies clearly show that normal protein intake doesn't worsen HE. The supportive care focus needs to be on getting them enough nutrition and aggressively fixing those low sodium and low potassium levels.
All right, so if lactulose is the foundation, then rifaximin is really the primary adjunctive therapy, especially key for secondary prevention, stopping HE from coming back.
Yeah, rifaximin, which is a poorly absorbed oral antibiotic, is typically used in combination with lactulose, usually for patients who've had recurrent episodes or refractory HE, or frankly, in almost any patient presenting with overt HE who you plan to discharge. The standard dose is 550 milligrams twice a day. Its mechanism is pretty neat. It works locally in the gut to reduce the population of bacteria that produce ammonia, but with minimal systemic absorption, so less risk of systemic side effects or resistance.
And the evidence supporting this combination is maybe some of the strongest we have for any HE intervention, right?
Mm-hmm.
Can you summarize those key findings that really made combination therapy the standard?
The evidence is really quite compelling. There have been multiple randomized trials, including that pivotal NEJM trial from years back, which confirm that adding rifaximin to lactulose significantly cuts down the risk of recurrent HE episodes, reduces hospitalizations, and lowers treatment failure rates compared to just using lactulose alone.
Okay.
And beyond that, pooled meta-analyses have shown this combination therapy isn't just better at preventing recurrence, it actually seems to offer a mortality benefit as well. The relative risk for mortality was reported around 0.69 in one analysis. So for us hospitalists, the takeaway is pretty clear. Any patient admitted with overt HE who survives should ideally be discharged on both lactulose and rifaximin unless there's a clear contraindication.
Wow, that mortality figure, nearly a 30% relative risk reduction, that's really striking. It underscores why this combination should basically be standard practice for secondary prevention.
Exactly. It shifts our goal from just treating the acute fire to actively preventing the next one, which could be fatal.
Okay, let's talk about some second-line alternatives, maybe things we might encounter more in the ICU, but often with significant caveats. Polyethylene glycol, PEG, lightly, sometimes comes up for rapid gut clearance.
Yeah, PEG is a consideration, particularly in the ICU setting.
Yeah.
There was one key RCT that showed it led to faster resolution of HE compared to standard lactulose dosing. It's obviously a very aggressive cathartic.
But faster isn't always safer, right? Especially in patients who are already altered.
Mm.
We need to talk about the aspiration risk here.
Oh, the risk is profound. That trial used a protocol giving 4 liters of PEG solution over just 4 hours. Trying to administer 4 liters of fluid to someone who is grade 3 somnolent or grade 4 comatose, That creates an incredibly high risk for aspiration pneumonitis, potentially leading to ARDs. So the bottom line is, if you're thinking about using PEG for rapid clearance in someone with advanced HE, especially grade 3 or 4, you absolutely must address airway protection first. Often that means preemptive intubation before you start pouring in that large volume. This significant risk really limits PEG as a standard choice outside of very closely monitored settings.
What about some of the newer ammonia scavengers like glycerol phenylbutyrate or GPB? Where might that fit in?
So GPB is an oral medication that works differently. It essentially bypasses the liver's urea cycle by binding up nitrogen waste products into molecules that can be excreted by the kidneys. It creates phenylacetylglutamine, which goes out in the urine. It's like a chemical nitrogen sink. And while it does effectively lower ammonia levels, its use is really limited by two big things. First, it's very expensive, which makes it hard to start and keep patients on it long term. And second, its effectiveness completely depends on having good kidney function. You have to be extremely cautious, or probably avoid it altogether, in patients who have AKI or significant chronic kidney disease because they just can't clear that phenylacetylglutamine efficiently.
Okay. And what about some of the older agents or less preferred ones? We occasionally still see flumazenil being used. What's the real role there?
Flumazenil, which is a benzodiazepine receptor antagonist, has a very, very limited role. It might give a short-term kind of transient improvement in mental status in some HE patients. The theory is it might reverse the effects of endogenous benzodiazepine-like substances that can build up in liver failure. But it doesn't improve mortality or long-term outcomes. And critically, using it carries a real risk of seizures, especially in patients who might have actually been taking prescribed benzodiazepines or other sedatives. So it requires close monitoring, has potential risks, and the benefit is usually fleeting, generally not a go-to.
And the older antibiotics like neomycin or metronidazole, any reason to use those over rifaximin?
Generally, no. They're much less preferred, mainly because of their side effect profiles. Neomycin has significant risks of ototoxicity, hearing loss, and nephrotoxicity, kidney damage, because it can be absorbed systemically. Metronidazole is usually better tolerated short-term, but its efficacy compared to rifaximin seems limited, and long-term use is linked to peripheral neuropathy. The data really supports rifaximin as the clear winner for the antibiotic adjunct role.
And just briefly, to be complete, probiotics and zinc, where do they stand?
Probiotics. Well, there's some suggestion they might help reduce the initial development of overt HE, maybe playing a role in primary prevention by tweaking the gut microbiome, but they haven't really shown a measurable impact on overall mortality or recurrence rates once HEE is established. Zinc supplementation seems to improve performance on neuropsychometric tests, so it might help with those subtle cognitive symptoms of covert HE, but again, it hasn't been proven to reduce recurrence or affect the hard outcomes like mortality or quality of life. So, interesting, but our main focus has to stay on the high-impact players, lactulose and rifaximin.
Okay, let's shift gears a bit to special scenarios. First, type A hepatic encephalopathy, the HE we see in acute liver failure. This is a totally different beast, a critical emergency needing ICU intervention.
Yeah, type A HE requires immediate intensive care focused squarely on preventing and managing cerebral edema. Airway protection is absolutely paramount. Intubation is indicated for anyone hitting grade 3 or grade 4 HE, or if their Glasgow Coma scale drops below 8. This is primarily to prevent aspiration and to allow for better control of intracranial pressure if it starts to rise.
And importantly, our standard therapies for type C HE, like lactulose and rifaximin, are viewed much more skeptically here, right?
That's exactly right. Currently, there's just not enough evidence to recommend using lactulose or rifaximin routinely in acute liver failure. There are concerns about potential bowel necrosis risk with lactulose in this setting, and frankly, a lack of proven benefit. Instead, the management focuses on aggressive systemic support, managing intracranial hypertension if it develops, and sometimes using targeted ammonia clearance strategies.
Like CRRT.
Yes. In specialized transplant centers, continuous renal replacement therapy, CRRT, might be used. It's a continuous form of dialysis, essentially, and it can actively lower systemic ammonia levels. There's some thought it might improve transplant-free survival. Standard intermittent hemodialysis is usually too aggressive and can actually worsen cerebral edema in this context.
Okay, switching back to our more common type C patients. What happens when someone seems truly refractory to maximal medical therapy? They're on full dose, appropriately titrated lactulose, and they're getting rifaximin 550 twice a day, but they're still having frequent severe episodes.
For those truly refractory cases where HE is severely impacting their quality of life despite optimal meds, we need to think about anatomy. A key step is to screen for large, previously unrecognized portosystemic shunts. These are abnormal connections that let ammonia-rich blood from the gut bypass the liver entirely and go straight into the systemic circulation. If you find a large shunt, and especially if the patient's underlying liver function is otherwise relatively compensated, then embolization of that shunt, basically plugging it up interventionally, can be considered and sometimes provide significant relief.
And if medical therapy fails and maybe shunt embolization isn't an option or doesn't work?
And then ultimately, liver transplantation remains the only truly definitive therapy for end-stage liver disease and refractory HE. Severe, persistent encephalopathy, despite doing everything else medically right, warrants an immediate transplant referral and evaluation. The MEL-LD score, which incorporates sodium now, is used for allocation, and having persistent severe HE significantly worsens prognosis and increases mortality risk, often prioritizing these patients on the transplant list.
Okay, let's bring it back to the inpatient basics again. Monitoring. We've firmly established that chasing serial ammonia levels is not helpful. So what is the structure for continuously monitoring these patients on the floor or in the ICU?
Monitoring is entirely clinical, and it's focused on tracking the West Haven criteria. Their neurological status needs frequent reassessment, often multiple times a shift, especially if they're critically ill. We use the West Haven grade primarily. The Glasgow Coma Scale, GCS, is also useful, particularly in tracking overall responsiveness in patients who are grade 3 or 4.
And we gauge treatment success by looking for that subjective improvement. Are they more alert, less confused? And objectively, has the astragus resolved? But we also have to monitor for the side effects of our main treatment, lactulose.
Vigilance is absolutely key there. Titrating lactulose to hit that 2 to 3 soft BM target is essential, but you have to constantly watch out for complications like excessive diarrhea leading to volume depletion or significant electrolyte problems. Aggressive catharsis can cause hyponatremia, high sodium from free water loss, and also worsen hypokalemia, low potassium. And these electrolyte shifts, particularly low potassium or high sodium, can paradoxically make the neuropsychiatric symptoms worse, creating a kind of treatment-induced complication.
Okay, and just to hammer it home one more time, that single most crucial monitoring takeaway for every physician managing HE.
Routine serum ammonia measurement is not recommended for monitoring treatment response. It distracts from the essential clinical assessment, the West Haven grade, and gives you unreliable, fluctuating data that really shouldn't guide your therapy adjustments. Focus on the patient, not the number.
All right. Finally, let's just consolidate the prognostic reality here. We know that progression to severe HE, recurrence, and the functional impairment it causes are all major issues.
Yeah, untreated or recurrent HE is truly devastating for patients. It's strongly linked to severe functional decline, things like high rates of falls, fractures, and impaired driving ability, which has huge safety implications. Importantly, progression to grade 3 or grade 4 HE during a hospitalization is independently associated with dramatically higher in-hospital and 30-day mortality rates, approaching that grim 38% figure we mentioned earlier. That number should really stick with us. It highlights the urgency of getting our management right.
And the data on readmissions is just as concerning.
Absolutely. Recurrence of overt HE is the #1 reason patients with cirrhosis get readmitted to the hospital. On the flip side, though, the resolution of HE during a hospitalization is a really important positive prognostic sign. Patients whose HE reverses before discharge have significantly better short-term survival compared to those who leave with persistent or unresolved encephalopathy. So our goal isn't just getting them through the acute episode, it's achieving resolution and setting them up for robust secondary prevention.
This has been a really thorough run-through of the challenges in HE management. Let's quickly summarize the core principles we've laid out. First, prompt, aggressive, systematic identification and correction of those precipitants, especially looking for hidden infections like SPP, GI bleeding, electrolyte problems. That's the critical first step.
Second, the nonabsorbable disaccharide lactulose is the absolute cornerstone first-line therapy. It needs to be titrated meticulously to that goal of 2-3 soft bowel movements daily, while always keeping an eye out for volume depletion and electrolyte issues.
And third, rifaximin, usually 550 milligrams twice daily, is the essential adjunct to lactulose, particularly for secondary prevention. The combination provides superior outcomes in reducing recurrence and hospitalizations compared to lactulose alone. And, of course, early specialty consultation GI or hepatology is key for severe type A cases, refractory type C, or if you think about things like shunt embolization or transplant.
And we really have to stress that managing HE extends far beyond just the hospital stay. The reality of covert HE, that minimal HE or grade 1 stage, is that it carries serious, often underappreciated socioeconomic and functional consequences for patients long term.
Yeah, and that leads perfectly into our final provocative thought for you, our listeners. If we know that even minimal HE can severely impact things like coordination and reaction time, making patients high risk for driving accidents, for debilitating falls, how effectively are our current hospital discharge processes addressing this? Are we just focusing on medication adherence, ensuring they leave on both lactulose and rifaximin? Or are we also robustly educating patients and their caregivers about these critical long-term risks? Things like structured fall prevention strategies and the absolute necessity of stopping driving until their cognitive function is verifiably back to baseline.
Right. Are we truly ensuring they understand the need for sustained adherence and safety management, or are we sometimes just writing the prescriptions and sending them out the door? It's fundamentally a transition of care issue, and how well we handle it directly impacts those persistently high readmission rates and mortality figures we've been talking about.
Managing HEE effectively is really a long-term commitment, and that hospital phase, while critical, is just the beginning. The success over the next year truly hinges on the quality and comprehensiveness of that discharge plan.
Well said.
Thank you all for engaging in this clinical deep dive with us today.